Good morning. Dr. Fox already made that joke about sounding better in your bio, so I can't make it now. It's really nice to be here. Thank you so much, everybody. And it was really interesting in Dr. Fox's presentation to hear about the continuous patient engagement protocols that you have in place, because that's something I want to talk about now in terms of building in patient engagement in clinical trials. So I want to say a quick thank you to Rachel McCann, Dr. Rachel McCann, who has worked with me on the Community Advisory Board for a PPI that we have established. I'm going to get into that now in more detail, but some of these slides are definitely relating to Dr. McCann's work. So let's go quickly through it. So a couple of years ago, the Infectious Disease Clinical Trials Network was established by various entities you see there, including HIV Ireland. And HIV Ireland is a patient advocacy and community organisation that works to advance the rights of people living with HIV. We're based in Dublin. We are essentially a national NGO. And my role there is, as was mentioned, Executive Director. So we were invited to participate in this particular project, and it's been a fantastic opportunity for an organisation like ourselves and our sister organisation, Positive Now, which is the All-Ireland Network of People Living with HIV, which is a community organisation of 400 volunteers, to participate in something like this. So it really is an important project. But the vision of the network is to achieve meaningful public and patient involvement, to have that embedded across the entire organisation, and to with active consultation and collaboration in individual research projects on identifying research themes and, where feasible, in developing user-led projects. So it's quite aspirational in terms of what it's trying to achieve. So I want to talk a little bit about this PPI. Now, many of you will understand public and patient involvement, have experience in public and patient involvement initiatives. This was our developed project, and I just want to go very quickly through how we think about it and why we're doing it. So involving patients and the public in clinical trials research is, to think about research being carried out with or by members and not to, for or about them. So that's really key. It's a really key understanding of it. When we talk about the public, we're talking about the key stakeholders who have an interest in health and social care as a public service, including potential users of the service. And of course, those users of the service are patients, very often patients. And we mean people who use the service as patients, service users, clients, and their carers. So it's slightly broader than just patients, in fact. And involvement really is about active involvement. So how do we get people to participate? How do we elicit their understanding, their expertise, their knowledge? What kind of involvement do we want to build into projects as they develop? So why is that important? Well, it helps to develop priorities and make improvements based on identified needs, rather than making assumptions about what people need. The end users of healthcare services may be best placed to identify where the gaps are, and consultation and involvement of patients and the public can help researchers to make projects more feasible and offer new insights into findings. And I was reading recently that there are kind of three pillars of sort of thinking around PPI engagement, and one is the kind of philosophical aspect of it, which is nothing about us without us, ensuring that people from an ethical point of view are included in aspects of research, development and implementation where they should be. There is the political side of this as well, which is the understanding that public funds are being expended, very often administered and expended on behalf of the public to develop research and to undertake projects. And so there is a vested interest both in the public and in the service users in terms of how that money is spent and what that money is spent on. And then there's the quality side of things, which is the kind of the most exciting part, which is listening to the voices of people who have this experience, this knowledge, can really help to drive innovation in terms of what should be researched, what should be prioritised, when and how. So, embedding that PPI into the project is something that should see real benefits. And actually, there is evidence to suggest that embedding PPI into research does drive participation, or there's some evidence to suggest that it's beginning to drive participation in trials and maintaining people in a trial throughout the course of the trial. So that is useful. I won't go through this too much because it's quite small and you can't really see it. But just in terms of at the stages or the points at which you can involve PPI or networks into the trials process really is a cycle. So there's at the design stage where people can help clarify the research question. They can think about co-designing the methodology that's going to be employed in the project. There's the actual undertaking and management of the project, right through to even analysing and interpreting results, or providing feedback on analysis and interpretation, or providing understanding or experience, or testing on understanding and evaluations. That's really important. Right through to dissemination, and dissemination will be an aspect of the work that, say, an organisation like HIV Ireland would be keenly interested in. How do we get the results of this research back to the people who are impacted by it? How do we make it understandable and accessible for them? How do we feed back their thoughts and their insights from that back into the research process? So it's really, really important. So when developing this, there was a sort of a set of self-assessed questions that the ID-CTNI sort of thought about in terms of how are we going to embed PPI into the Clinical Trials Network for Ireland for ID. What are the goals that are to be achieved? How much influence and decision making would do public and patients have? At what steps do we want to involve public and patients in the project? What resources will we need? Which is a key thing, because for organisations like HIV Ireland, where we're asked to engage with patients on behalf of clinicians, and it's vitally important for organisations like HIV Ireland to have strong and good relationships with clinicians right throughout the sector, and we cherish those. But in order for us to engage with the community and engage with service users, that takes time, that takes effort, that takes resources, and it's something that sometimes is a bit overlooked. What timelines will be involved? And this is something people will always want to know. Like, what's the time commitment? What are the timelines? When will these things be completed? How much time are you asking me to contribute? Who do we want to involve and why? And how many people are going to be needed? How are we going to recruit people? And as we think about recruiting into our PPI, we attended the HSE's Public and Patient Information Network seminar last week in the National Conference Centre, really well organised. And all of the discussions that we had with our colleagues there from other PPIs was recruiting. How do we recruit people into the PPI and retain people into the PPI and get people to be involved? What skills and expertise are we looking for? And again, what costs are going to be incurred? So all of those things were thought through as we decided to develop this model that we wanted to implement for the CTNI PPI. And when we did that, we settled upon developing a community advisory board. So a board that would be a bridge between the PPI itself and the CTNI steering committee, which would sort of help transfer that information between the steering group and the PPI network, that would help in the oversight and development of the network, that would sort of really sort of ingest the ideas that wanted to be conveyed and sort of think about how and why and where is the best way to sort of engage the group that we wanted to do that. And it's tricky, you know. So having a community advisory board of really interested patient advocates, I have found that really beneficial, because it can be an onerous task to try to engage people on a broader scale at the beginning of something like this. So I have to say the Community Advisory Board has been a real innovation for me in terms of what it's been able to bring to the project. And it's allowed us to sort of engage with different PPI representatives or interested representatives to build interest in the project and to build knowledge and expertise. So we have a number of people, and I'll talk about that in a minute. We have a number of people from different patient groups, from different areas that are being researched by the CTNI, already interested in sort of contributing and developing this and sort of feeding back to them, their stakeholders and people that they're in touch with about why this could be beneficial. And that, again, we hope will drive engagement and recruitment. We initially thought we would sort of meet every 3 months or 6 months, depending on the projects. That's really beginning to ramp up. We want to engage the PPI members in some training, because there is training in terms of developing good PPI, and we have made really good contacts and connections with PPI networks both in Ireland and beginning to do so at the European level, which is really useful, and it has helped us to sort of really understand what we want to do. And as we did all of this, we involved the CTNI stakeholders, and we put a structure on the CAB, and we reached out and we recruited members to be involved. So I'm chair of the CAB at the moment, and I'm ably assisted by Dr. Rachel McCann, who really is the driver of the knowledge side of this, and also by Dr. Plina Smolovic from UCD, who's working with from CEFR, who's working with Professor Paddy Mallon, and is really the engine of this particular organisation. And then you can see there the well-known ID clinicians who are working across the CTNI network at the moment, and who are giving us their time and expertise, and are seeking input from the CAB. So there really is really good and really top-level engagement between patient advocates, people who have a keen interest in what might be researched, or how research is ongoing, and how they might feedback that to their cohorts, and the clinicians themselves, which I think is really beneficial. Some of the contributors to the CAB are listed there. So people who are advocating in relation to long COVID, for example, people advocating in relation to HIV, advocating in relation to MPOX. And that's the kind of areas of the CAB that at the moment, and the trial work that's ongoing at the moment, and that can be expanded and developed upon. And in that process, we have already had, I think, really concrete engagement from patient advocates into the trials process. So, for example, Adam Shanley, who's there talking, who's there representing people who had acquired MPOX, and has done a lot of work with the community of people impacted by MPOX, has helped to advise on the study protocols already. HIV Ireland has helped to advise on the development of I suppose co-designing an aspect of I'll come to it actually, the SWIFT trial. I'm going to come to it actually in a moment, because I have a slide on it which is kind of interesting. But the reason I bring them up is because those people are linking back in with community representatives, sharing that knowledge back into the community, and when they do that, we find people really sit up and are interested in what's going on. So we've been involved in the SWIFT study, which is looking at semaglutide, and every time I meet the people that I spoke to initially about aspects of that study, every time since then, those people in the community have asked me about that study, asked me how that study is progressing. They remember it, it is embedded in their brains, they won't forget it, precisely because we asked them initially to give us information, to give us their feedback, and that's really key and beneficial. So I can't overstate the benefit and the obvious benefit from doing that. So just, I know I'm running out of time, so I want to talk a little bit about, we had an idea for a PPI, and we had an idea to develop the Community Advisory Board, but what kind of model of engagement did we want, or what kind of model is best suitable? And there's lots of models for PPI engagement out there, and they're all well developed and well researched, and I suppose it's tricky to sort of figure out which is most applicable. I've listed a few up there, but the one on the bottom there, the ladder of participation, by sort of first developed by Smith and et al., is the one that sort of strikes me as the model that sort of fits what we're doing. It sort of seems to be what occurs. And in my short time with HIV Ireland, I've been there 4 years now. When we do think about research or people being asked to participate in research, or information coming from the clinical side, we sort of see ourselves sometimes in that model. So this is the ladder of co-production, ladder of participation in relation to co-production, which begins at the bottom, where you might be just informing people with a very one-way communication around a trial, a project, the development of a service, for example. And that's fine. None of this is wrong, or none of this is bad, or none of this is to be thought of as as not attempting to engage, because there's an attempt to engage on all of these steps. But we can see ourselves, or the patients or the service users can sometimes see themselves where they land on the ladder of participation. And oftentimes it's down towards the bottom around the informing or around the sort of tokenistic sort of aspect of it. And what we're trying to do with the CAB and the PPI and the CTI network is to move up this ladder towards much more meaningful engagement, towards a co-production model for research. Nobody ever arrives at the top. That doesn't happen. There's a lot of things that need to be put in place, things that need to be done, strategies that need to be developed, time and effort that needs to be put into it to ensure that people are sort of beginning to sort of have that level of engagement which sits on the more meaningful side of things. So something like, peripheral involvement, for example, where patients are involved in projects but there's a limited scope to influence, and sometimes maybe the involvement might come too late. That's an experience that certainly service users that we know will have had in the past. And then you draw that sort of elevates to something like co-design, where patients are receiving a service. The patients receiving a service are partners in its design from the outset, and I'm going to talk a little bit about that shortly. And when that happens, you really get that meaningful engagement and that want to know and understand more about what's happening and that want to participate in the future. So we think it's really, really beneficial. So as we think about this, how do we, if we are having this CAB and if we want to develop this PPI, and if that PPI's raison d'etre is to, influence or impact or co-design research, how do we do that? Well, there's a number of things you have to go through, and I list them here because I think it demonstrates the breadth of work that's required to do that. So you have to assess the current status. So you evaluate the existing level of PPI in clinical trial research. It might be very good, it might not be. You identify the gaps where the improvement is needed. You set your goals then. So you determine what desired level of PPI engagement, thinking about your ladder of participation, for example. What is the desired level of participation? You set clear and measurable goals and objectives, which we're all very used to doing, but you do that in a way that ensures that you are continuously evaluating the engagement. 3 minutes, thank you very much. Then you identify your stakeholders. You develop your strategies, and actually developing a coherent PPI strategy is a significant body of work and time in itself, and it's something that we're learning by doing in the CAB and in the PPI network. And then you implement that strategy, and then you evaluate and monitor the outcomes. So I just list them there because you can see that it's not something that just, as I say, arrives overnight. There's a lot of work and a lot of time and effort and a lot of meetings, a lot of engagement that's required to ensure that we get there. The last thing I wanted to say is, during the CTNI process, we've had real experience of that little bit of sort of co-designing at the top there, or near the top there, of research. And I want to say a special thanks to Professor Peter Carey, who's here, and I think Dr. Lydia O'Sullivan's here as well, who involved HRB Ireland in the very early stages of the development of the CAB in an aspect of a trial that they're running, the SWIFT trial. And this was a study within a trial, which was looking at, let me describe it. So the idea here is that paper-based participant information leaflets, as we're all aware of, are becoming longer and often too complex for many participants to understand or to really get around. Multimedia interventions have been trialled in an attempt to improve patients' understanding, but there's little evidence to suggest that that improvement actually happens. And so what the SWAT was doing was going to evaluate the use of a multimedia resource, which was provided in addition to an enhanced patient information leaflet. And at that point in the study, we were invited to work with the study team to help develop and design that patient information leaflet in a way that we felt, and based on the discussions that we had with our cohort, would be more beneficial, would be more understandable, would be more comprehensible to people perhaps using, people who are engaging in that study. And as I say, the benefit that has had on people that we engage with, I just can't overstate, as I've said already, how many times I've been questioned about that study. So I've seen the actual benefit of this, of PPI engagement, lighting the fire under people and saying this is something that you might be interested in, and that person saying, I am very interested in it, but I've never known how to actually access or to sort of action that interest. And the PPI gives me an opportunity to do that. And what we will get from that is really coherent, really cogent, really interesting studies. And I think that's very useful. So thank you very much.